Good morning, everyone. I'm Sovannary Tuot from Cambodia. So, on behalf of my teams, it is my great honor to present, our research entitled "The Improving Mental Health of People Living with HIV/AIDS through a community-based and AOV deliveries, a quasi-experiment studies." So, this implementation research was implemented under the direction and leadership of the National HIV Dermatology and ICI CANA, a leading national governmental organization, and the its partners. So this is my disclosures. So first, let me present you briefly the national HIV status of and its prevalence by target population. Looking at to the 1995, Cambodia reached the last two, while only 89% of the estimated people living with HIV know their HIV status. So approximately about 70,000 ALTs, active patients. The HIV prevalence is concentrated and vary according to the key population. Transgender women is relatively higher. Let's move to the backgrounds of the study. Depression among people living with HIV is often exacerbated by stigma, discrimination, and socioeconomic challenges. Community-based interventions have shown promise in addressing the issue by improving socioeconomic conditions and social support system, reducing stigma, and fostering a sense of inclusion and well-being. Mental health is an essential component of HIV care and play a critical role in adherence to treatment and overall quality of life. So in Cambodia, community-based ARV deliveries, CAD has emerged as an innovative intervention to the people living with HIV/AIDS. So the studies, therefore the objective of the study is to assess the effectiveness of the CAD intervention in enhancing mental health outcomes, especially focusing on depressive symptoms among stable people living with HIVs. Before going to see the result, I would like to flag, a bit about the model that's, by the people living with HIV/AIDS. Establish a committee ART group between 15 to 20 members. The committee action worker is recruited as a leader of the group to facilitate with healthcare workers, including the ART physician, pharmacists, to collect and dispense the drug to the group members. Socioeconomic and mental health support are embedded during the monthly session in the committee sessions. This the operational frameworks and patient flow charts. So this the two group, participants. On the left side, you can see on the left side what we call multi-month dispensing, receive standard of care, assessing individually at ART clinics. While the CAD receive the same health care packages, but facilitated by leaders who collect prescription and refer at the pharmacy, pick up prepackaging, dispensing to the members to facilitate the monthly group session and refer unwell people living with HIV to ART clinic if needed. We register about 4,089 stable people living with HIV at the baseline and able to include about 75% at the endlines. A quasi-experiment study was deployed for the studies. The data were collected in 20 ART sites out of 72 sites in the capital city and 9 provinces in Cambodia. 2 times of data collection at baseline and endline of the 18-month interventions. The depressive symptom was measured using CSD-10 with cutoff 10 modern score defined as heavy depression symptoms. Different analyses were conducted to evaluate the impact of CAD on the depressive symptom. We include about 4,000 people, stable people living with HIV in the baseline study survey. The two, looking at this, the two account similar numbers. the intervention and control, approximately 2,000 each, while we complete about 79% of participants in the CD and 70% in the MD groups at their lines and end lines. Notably, the present symptom increased among participants in both groups. The increase in the CD group was less pronounced than in MD group. Figures, so you can look at the figures at the baseline. You know, the figures show the poorer of CAD at baseline, 21.7%. However, the between group differences at the end line was not significantly different. Adjusted model indicate that CAD participant has maintaining no depression symptom than though in the MD group. This advantage corroborated by a significant DAD estimate of about 6%, indicating a smaller decline in the proportion of participants without depression symptom in the CAD group related to the MMD groups. So in conclusion, the finding revealed a concerning overall rise in depression symptom among stable people living with HIV in both groups. You can see from the figures, likely, exacerbated by the psychological impact of the COVID-19 pandemic. Just would like to flag that the intervention was 18 months during the COVID pandemics. Despite this increasing, the CAD intervention proved more effective than the MD model is mitigating rise in depressive symptoms. The results highlight the potential of CAD as a valuable strategy to improve mental health outcome for people living with HIV. Further scale-up of CAD accompanied by a target mental health support may significantly enhance the well-being and treatment adherence of the vulnerable populations. We would also address the mental health needs of people living with HIV is crucial to achieving the comprehensive HIV care in Cambodia. So last but not least, I would like to acknowledge the donor. The initiative is pretty strong, and the project was led and managed by under the leadership of the National HIV Dermatology and ICD, UNCHAD, Ministry of Health, and thanks to our partners, National University of Singapore and the local implementing partners, the specialized NGO providing HIV care and support programs. If you would like to see further of this trial, you can access to the study protocol, and the impact study is being undergo for the publications in the near future. So thank you for your attention. If you have any questions, please. Thank you.